Then we're gonna talk about what's Accutite itself, and take a brief review about the anatomy of the periocular area and some clinical findings. What can we find in the periocular area? And the most important take-home messages, we're going to talk about patient selection and looking for our best candidate for this procedure, and a few tips about the technique with the Accutite. And for those who are not familiar with the technology, Accutite is what is called injectable radio frequency. This is the handpiece, and this is like a forceps where you place the probe that is down here like a gold thing, just under the skin, and the other one, the violet one, is over the skin, and then you pinch the forceps and switch the pedal, and then there's a frequency, radio frequency, that counts from one pole to another. The size of the is like a common cannula, is like 50-60 millimeters long, and as you can see here, it's a minimal invasive treatment. And when we have this probe placed in a proper position, then you switch the pedal on, and then there's something that happens. No, there's an internal there's a epidermal thermal contact and the upper probe that is over the skin, where you can achieve a non-ablative subnecrotic gentle dermal heating with this external electrode, that is positive electrode, and with the internal electrode, there's the where it's the origin of the flow of the radio frequency that comes from the inside out. And then there's something that happens in this area between both poles, as you can see in this picture, where you can see that from this surface you can achieve a thickening of the dermis, the collagen, new collagen product, and remodeling of the surfaces. And there's a vertical contraction of the fibroceptal network that's under the skin. So as well, you can achieve superficial fat remodeling with the heating of this area. So to sum up, I would say that this Accutite device, what's looking for is to achieve a shrinkage contraction and a contraction of the soft tissues between skin and the superficial fat that's under the dermis, right? So you can look for a softening of the wrinkles and tightening the tissues, and improving the fat prolapse that could happen sometimes in this kind of patients. So this is an example of what we can achieve with this technology. This is some people used to call it like a non-surgical blepharoplasty. I don't know if it's a good option, because but it's okay. It's a non-surgical. It's something that can be performed under local anesthesia with no skin scars and no stitches. So why not? It's a non-surgical blepharoplasty. But to achieve this result, this is a very nice result. You need to select very well to your patients. You need to. This is another result, for example. But you need to know very well the properties of the device, and you need to select very well who's the ideal candidate for your treatment. So a few words about the specifications of the device. As I've said, there's the length of the probe that is under the dermis is like a 6 centimeters, and you just need to make a small hole with a 21G needle, and then you place the probe under the skin, right? And then you can, first of all, you need to adjust the power of the radio frequency that's going to flow from the inside to the outside. It's going to be up to 16 BTUs, right? And so it's an injectable subdermal heating. What are we looking for? That's in the surface. You can achieve like 40 degrees. But in the internal area, in the subdermis, you can go until 70 degrees. So it's a very important heating, so you can achieve that shrinkage of the soft tissues, and there's no need for aspiration after that. So there is a very precise point heating that we are trying to achieve, and this is very important in this kind of patients because this is a very narrow area, very small area, and there's no space for mistakes. Okay, this is some specifications of the handpiece, and there's a thermistor that's embedded in the external electrode and the cannula tip, so you know exactly at every single moment what's the temperature that you have in every single arm of the forceps, in the external and the internal. As internal as a plastic protector to prevent any accidental skin perforation, and then the heating comes, as I've said before, from the inside to the outside, because it's a sorry, that's okay. From the inside to the outside. So you can see here that the most important, you can achieve it in the deep area close to the internal electrode, internal probe. All right. So talking about this kind of technologies, we're talking about this Accutite device, which is a invasive or minimal invasive technology. So, but depending on the size of the probes and the power that you are looking for to retract the tissues, you can look for another kind of handpieces. For example, the face type, so the next one, or the bigger one is the body type handpiece device. That's for I used to complement for liposections. Okay, but most of the time you can see here on the left side here the Morpheus 8. We've been talking about this technology last week in another webinar, but this for those who are not familiar with Morpheus 8, Morpheus 8 is a kind of radio frequency, but it's no invasive in terms of the same terms as Accutite, because you are using a handpiece that you only place it over your skin, and there's 25 small pins or small needles that comes from the outside to the inside, and once they are in the very deep, then they flow the radio frequency pulse. But you cannot achieve more than 4 millimeters. So this is both technologies, Morpheus and Accutite, in my opinion, they are very synergic, right? As you can see here, this is as far as the depth of the Morpheus could be around 4 millimeters. With the Accutite, you can go until 1 centimeter or something like that. Sorry. I'm going to show you a small video. I apologize because in this kind of presentations with webinar, due to the communications, you know, the technologies, the videos can be seen a little bit. It doesn't run properly. So as you can see here, you do a retrograde fashion. We used to perform in a retrograde fashion. You can do it in a stab fashion as well. That's not my gold standard. I used to place it from the this retrograde fashion. As you can see here, I'll try to place these videos in the Instagram, just if you are curious enough to take a look. And this is Morpheus. As you see, that is the complement that used to perform after the end of the surgery. Sometimes we use autologous fat transfer, as you can see here, and then at the end we place the Morpheus at 1-2 millimeters depth to have an extra effect on the surface of the skin. So we're gonna take a brief review about anatomy of this area, because we are all physicians, or most of us, we are physicians. We know more or less the anatomy, but I want to point out what's the most important thing around the eyes, talking about practice. I mean, when you're planning to use this technology, what do you need to know? How do you use the technology? Where do you place the probe? Okay, so let's take a look. If you remove the skin and this around the eye, you will find the orbicularis muscle. This orbicularis muscle, right? This auricularis muscle reaches until the end of the orbital rim of the bone, okay? And below the muscle, you will find this roof. This is retrorbicularis. This is not above the auricularis. This is not a very good picture of where the roof is. And if you remove the muscle, then you'll find a key structure here. It's called the septum, that divides the spaces of the orbit of the behind the septum. We used to call it the intraorbital space, and in front of the orbital septum, the areas where you can see the skin and the muscle. This is an extraorbital area. Septum is very important structure because it is where the orbit defends from infections and some other conditions. And when we're trying to perform this non-surgical blepharoplasty with this Accutite device, we place the probe, the internal probe, between the muscle and the septum. Okay, if you want to improve the appearance of the skin, then you use Morpheus. But if you want to improve the laxity and you want to go for a more important fight against laxity of the tissues, you need to place the probe underneath the muscle, right? So trying not to perforate the septum. This is very theoretical. It's not easy to be sure that you are not doing a perforation of the septum, but you need to go with the probe underneath the orbicularis muscle, because after behind the septum you'll find the fat pads. All right, these are the fat pads. And talking about anatomy, the most important thing about fat pads is that we have between fat pads, between the internal one and the mid and the central one, there's a very important structure that we call it the obliquus inferior muscle. And if you try to heat this area with enough temperature, you can damage the muscle and then you can have diplopia. So that's the reason why I advise you, if you're starting with this technology, please try not to go very deep, because the deeper you are, okay, you can achieve a better fat pad retraction, a very good improvement, but you are in a risky area. So be careful, because the oblicular inferior muscle is around there and you are working blindly. So please, for starting physicians, work as superficial as you can, but below the orbicularis muscle. Talking about vessels, there are not many important vessels in this area. You're trying to work kindly and smoothly. You will not find vascular damage, but please take care not to go too close to the medial canthal tendon, because you'll find there the angular vein and the lacrimal drainage systems, and that could be risky if you hit that area very, very closely. And talking about nerves, and only nerves that need to be pointed out as the supraorbital and the supratrochlear artery and nerve that runs like here in this area, in the nasal internal area of the orbit. So do not try to work very, very deep in this area. But okay, this is as axial view of the upper eyelid. This is another picture just to point out that it's very important to place the probe over the septum. Okay, this is the septum, this is gray line, and you need to place the probe over the septum. Do not go behind the septum, do not go deeper than the border of the orbital rim. It's called arcus marginalis. The same thing for the lower eyelid. You have here the globe, you have here the tarsal plate, and these are skin and muscle. And behind the muscle, you'll find the septum. In this case, there is a fat prolapse that changes the shape, the normal shape of the septum. Okay, and you need to go with the probe behind these two structures. If you want to go a little bit behind the septum, okay, you can go, but do not go further away from the arcus marginalis, because there are the rectus inferior oblique, sorry, the obliquus inferior oblique muscle in here, and as I've said, you're working blindly and it doesn't work. Okay, so when I've been talking with the company about what can we teach to our colleagues in terms of how to get a good result of the patients, in my opinion, it's much more important for you to understand which patients are ideal candidates or not. It's not about how to use the technology, because if you have the technology, you use it for some other areas, you know better than me how to place the Accutite device. But you need to understand very good which are the ideal candidates, and that's the reason why we're going to talk about more deeply, because once you don't have a very good result, I would say that most of the times it's due to poor candidate selection, not that the technology doesn't work or your technique doesn't work. Okay, so we're going to talk about upper eyelid clinical findings, and we need to focus on these 5 points that are very important for you to understand. You need to understand if the position of the brows is high or low, if there's any excess of skin or excess of fat, if there any asymmetry, or if the patient had an eyelid ptosis. For example, this man, where you can see that there's a good enough brow position, and there's only skin excess on the upper eyelids. This could be a moderate, good candidate, not the best, but it's not that bad. Okay, for example, in women, you know, as you can see here, with a thinner upper eyelid skin, but very good position of the brows. Okay, that could be a good patient, but these are findings that you will not find always. You need to know what other conditions can you find in your patients, so you can be sure if that technology is going to work or not. For example, let's take a look at some other patients. For example, this young man with this lower position of the brows with a very fatty upper eyelids, you will not find any result if you're treating these patients without surgery. I mean, you need to understand that this patient needs surgery, okay? In my opinion. And some other patients with heavy eyelids, even eyelid ptosis, for example, with a lower position, with a low position of the brows, for example, it's a very, very tough situation. You want to achieve a non-surgical blepharoplasty in the upper eyelids of this kind of patients. But sometimes there are other conditions that could be misdiagnosed with dermatochalasis, for example, in patients with thyroid eye disease conditions, with a very important retroorbicularis oculi fat hypertrophy. As you can see here, that's remember that this is the fat that this is behind the orbicularis muscle, and this is placed under the brow, and sometimes you can find a very important hypertrophy. And in these patients, as you here with the orange arrow, these patients, you need to, you can treat them with the Accutite, but you need to go with the maximum power as possible, and it's going to need a very good anesthesia of the area, and the downtime, assuming that you have been used a very important amount of energy on this area. You're going to improve this area, but need to understand that it's going to take a little, like 10 days to 2 weeks of downtime. And for example, these patients with upper right eyelid ptosis, please do not try to raise the eyelid only with non-surgical techniques, because it's not going to be enough. It's not going to work. So this patient, you better look for a colleague in your area that works in that has experience with eyelids, and you can achieve a very good result in terms of surgical options, but with Accutite or with Morpheus, I don't think there's gonna be enough for this kind of patients. As you can see here, for example, this patient is a young man with, we're talking only about upper eyelids. We'll talk about later about lower eyelids, but in upper eyelids, for example, you don't see here a very important skin excess, but you can take a look. There is a very low brow position. I mean, it's not a very low brow position. It's a common position in a young man, but it's very tough for you as a physician trying to raise the brows without a surgical option. Okay, I want to be I want to tell you this because in my experience, it's very difficult to raise the brows enough so you can improve the look of the upper eyelids. And sometimes there are some patients that they are not that common as we have seen the other patients, but this patient, for example, there's a slight enophthalmos where there's a prominent orbital rim and there's not much skin excess, and the patient says, well, look, my eyelids are like droppy eyelids. I feel like I'm tired or I haven't slept enough. But the thing is that there's not a skin excess condition. It's a condition where the orbital rim is very prominent. So with this kind of the technologies, you are hitting soft tissues. You cannot change the shape of the orbital bone of the ring of the orbit. So you cannot change the appearance of these patients with any kind of technology. Okay. Sorry. So I hope you understand that this patient is not very good candidate for treatment with the Accutite device, or this is another option for very poor candidates to be treated with an Accutite device. For example, this asymmetry. In this patient, there is an asymmetry between both upper eyelids. You can see in her upper left eyelid, which is this one. There's a hollowing of the fat in this area, and it's a double fold skin here. You can see there's only one skin crease here, and there's a double in here. Can you see the difference? Okay, you can treat these patients. Nothing bad is gonna happen if you use Accutite or you use Morpheus. But if you wanna be accurate enough to achieve what our patient is looking for, probably you will need to go for surgery, because with the Accutite device, you can improve very much the appearance of the skin, but it's very difficult to achieve symmetries when there's a very important asymmetry at first, preoperatively. So in my opinion, if you're starting with this technology, which are the best candidates for upper eyelids? Well, I would say there's a very good brow position, or the higher the better, with a mild skin and no asymmetries, without any eyelid ptosis, not very fatty eyelids. Could be a mild fatty eyelids, that could be okay. Okay, for example, this could be a good candidate for you to start with. And upper brow, without a very high, low brow position, with a mild skin excess, with a mild fatty upper eyelids, that could be a very good candidate in my opinion, as well as could be this, which has I don't know if you can see it well, but there's a slight asymmetry between both, because in this area we don't have enough fat in here, and you can use the Morpheus here or the Accutite. You can tighten these soft tissues enough to improve that asymmetry. Okay, we're gonna go further and talk about lower eyelid, which is much more common to find. I mean, the patients used to ask for lower eyelids much more than upper eyelids in my practice. But what do we need to take care of? For more or less the same things I have said for the upper eyelids, but with some differences that I'm gonna discuss. For example, Is there any excess of skin? Is there any excess of fat? Is there any eyelid retraction? Is there, how deep is the tear trough? And what about laxity? Okay, you need to understand, and this is the most important take-home message in my opinion, that treating eyelids with this device of radio frequency, I would say that it's for advanced level physicians, not to start with. If you're starting with the device and you're starting with Accutite, you better start with nasojugul or neck, or even axial hyperhidrosis or some other areas. But for periocular area, you need to have enough experience. So you better start your learning curve in other areas and then you go through a periocular area, right? That is my humble opinion. And which is the ideal candidate for these patients? Okay, these are 5 points that we're going to discuss a little bit just to point out what's important or what's not important. For example, the tear trough. The tear trough is being graded by Hindrist in 2010, if I remember well. There's a grade 1 could be this, the slightest one, and the grade 2, and this could be the grade 3. If you have a grade 3 tear trough length or depth, that's not the best candidate. For example, this patient, this is not the best candidate because you need to fight against a very important laxity of the tissues, and then you will need a very important rising of the temperature in this area, and then the higher the temperature, the higher the risks, and the longer the downtime. So you better try to start with patients with tear trough grade 1 or grade 2. Which one could be a good candidate? For example, I would say myself, I don't have very important fat prolapse. I do not have a very long or deep tear trough. I do not have orbicular hypertrophy. Could be a good candidate for periocular rejuvenation with Accutite. Okay, the second point would be the skin excess. Okay, we're talking about this technology that is heating the areas between skin and muscle, and this heating is improving the laxity of these tissues, and they are tightening these tissues. But with there are some limitations. You cannot try every single patient you want to. You need to understand that this heating is going to improve mild to moderate skin excess patients with skin sex. For example, this patient, there's a very important skin excess in here in the lower eyelids, and this is not the best candidate for you to start with. And for example, which would be a better candidate in my opinion? I would say this patient, there is a wrinkles, there is a thicker skin surface, and there is no very important fat pads, as you can see here. Okay, this point is about patients without edema or without mild edema. Okay, you can try to treat patients with edema with Accutite and Morpheus, and you can try some other techniques. But if you're starting with this technology, one more time, you better try to start with patients with mild edema, because when you find some patients like this, for example, or these patients, the first thing you have to understand is that most of them may have another condition that takes them to this edema, to periocular edema. And it's very important for you to study where are the causes that can take you to this condition. The most frequent condition is thyroid eye disease or Graves' orbitopathy. Okay, and once you have you are sure that this patient doesn't have these conditions, then you can start to treat this area. But one more time, don't try with severe cases like this. Can you see this malar or malar mound or malar edema? It's very important. And when you use this Accutite device, what you're doing is heating the areas between both poles, and it works like a wax stamp, like they fix layers. And we have seen some drainage of this MALAR mounds. We have not enough experience to give you some recommendations about that, but we are looking at very good results, and I'm sure in the future we're going to discuss later. We're going to have news about this condition. You better start with mild patients with mild edema. Try to look for a patient who doesn't smoke. It's better for you. Will shorten the downtime. For example, this patient, as we've seen before, and mild fat prolapse. Okay, this is most our patients said, "Oh, I have this fat prolapse in here. I want you to improve this, but I am afraid. I don't want to go through surgery. What can we do?" Okay, you can do Accutite device. You can improve the situation. You can improve the condition, but it's very important to make our patients understand what can we achieve. If you want a very good result, you need to understand that the patient needs to have a mild fat prolapse. If it is very important fat prolapse, you're going to achieve a partial improvement, but not very, very good improvement. For the words that I have said at the beginning of the talk, because you shouldn't go very deep with the Accutite device to hit the fat and looking for a contraction of the fat. So if you have, for example, this is an example of Dr. Shar-Pol from Austin, Texas. It's like you can achieve a very good result, but when you have a mild fat prolapse, right? Okay, and in the end, for example, if you have a moderate fat prolapse, this is not a good candidate for to start with. This is a very advanced level, and I would say this is a surgical patient, or more severe, even fat prolapse. Okay, this is another result combining both technologies, Accutite and Morpheus. Okay, and in the end, I'd like to talk about a few words about laxity or eyelid retraction. This is the same patient we have seen before, where there's an important skin excess. And as you can see here, there's a slight asymmetry between the right eyelid and the left eyelid. The right eyelid looks like bigger, looks like very wide open. And the reason is there's a small or a slight lower eyelid retraction. As you can see here, this white scleral show in here, like I would say 2 millimeters. For me, when I found this, I'm sure that the patient has a very important laxity. I don't need to touch it. I just know, because this kind of differences and this retraction with this skin excess, most of the times is due to the laxity of the tissues. So if you need to explore and touch the patient just to feel if there's very important laxity or not. Patients without laxity are the better to be treated with, right? And patients with negative vector, with very bad malar support here, as you can see here, they have a stronger tendency for the eyelid to go down after you hit the tissues. So you can worsen the condition of the retraction. So be careful in this patient. So this is a nice result, as I showed you before. So I will end the talk with talking about the future of this technology, because as a technology that is relatively new, and what are we going? What I think is going to be the future, and I hope I could be helpful in this to treating these conditions. For example, the severe festoons or malar mounds. As you can see here, we need to gain experience in this kind of patients, because this condition 1-2 years ago, when we were starting with this technology, we didn't have any any other gold standard options to achieve a successful result. Nowadays, we are achieving very good results, and we don't have very long-lasting experience. I mean, the experience not more than 1-2 years. But I've been talking with some colleagues from California and some from America that are much more experienced than me, and they have shown me very good results combining Accutite, Morpheus, and some other techniques. Sometimes they use CO2 lasers and some other techniques, but a few years ago we didn't have any proper solution for this condition, and I'm thinking that this is going to be a very important tool for these patients that are very difficult to treat. Oh, dark circles. Okay, when you're using this kind of techniques, you are hitting the tissues, and there's a mild risk of periorbital hyperpigmentation. That's okay, but what we are looking what we are seeing in these patients, if you have a very important periorbital hyperpigmentation, it's very difficult to achieve an improvement with Accutite or with Morpheus. You can achieve it, but will be mild. But when you are treating patients with a slight periorbital hyperpigmentation, sometimes this hyperpigmentation is due to the laxity of the tissues. And when you improve and you tighten the laxity of the tissues, then the surface softens itself, and you can see an improvement in color. And that's something that I think is going to be another promising technology for this kind of patients. The differential diagnosis of periorbital hyperpigmentation is too long to explain here, or a treatment is too long to explain here, but I think it's going to be the future. Okay, and the last condition that I think that's going to be that we are already treating with these patients is the orbicularis hypertrophy. The orbicularis hypertrophy, by now we only have the tool of the botulinum toxin to treat these patients, but most of the time the botulinum toxin in this area only lasts like 3-4 months. Okay, patients are looking for a more long-lasting treatments, and I think that in this kind of patients, we have a good solution with the Accutite device. I'll show you what's the orbicularis hypertrophy condition. Okay, this is orbicularis muscle. It's a round shape around the orbit, and the area that is closest to the lashes line is the area where the tarsal plate is, and it's called the tarsal orbicularis. Okay, in this area, sometimes you'll find a thickening of the muscle, as you can see in this patient in here. Here, this patient, as you can see here in the lower eye, you can see there's a kind of a double fold in here, this one and this one, right? So if you take a look to these blue dots here, this is the area that delimits the lower border of the tarsal plate, and from here to the lashes there is a thickening of the orbicularis muscle. Okay, sometimes some physicians can misdiagnose this area with the red dot line. There's a T-trough itself, where you have treated with, you want to improve T-trough with hyaluronic acid, you treat this red dot area. But if you want to try with hyaluronic acid to improve the fold of the blue dots, it's going to be tough. It's going to be risky. It's going to be difficult. You need to be quite skilled for achieve a good result to improve the fold that is under the tarsal plate, because there's no bone support behind, and the placement of the hyaluronic acid product is too superficial, and this is not a condition that I would recommend to treat with hyaluronic acid. You can be successful for sure if you treat it with your botulinum toxin, the orbicularis hypertrophy, but they only will last 3-4 months. For example, I will show you another patient. This is another patient with orbicular hypertrophy, as you can see here. Okay, and the Accutite should work in this area from the dust to the lashes. All right, it's a safe area because under the muscle there is only tarsal plate. It's cartilaginous tissue. It's not easy to perform, much more rigid than the septum, and you can work in this area properly, and it will be safe. But when you're working down there for the tree trough, okay, just want you to know the differences of the folds, okay? So I'll show you some in-mold physician partner results that are made for Dr. Mulholland from Canada, who's the inventor of the technology, has a very good plastic surgeon, very well-renowned plastic surgeon in Canada, and you can see some results of Dr. Mulholland, but I don't want you to take home message. This is an easy way to achieve a good result. Okay, this is a very good result. I mean, this is amazing result, but you need to be experienced to achieve this result or this one. So, okay, can you see here? Talking about face, there is no skin scar here. There's a non-surgical procedures for all the full face. Okay, so I'm done with the talk. Hope you say some take-home messages, and I'm willing to hear your questions. Please be safe at home, and hope you are all doing okay and doing well. I'm here to listen for you. Okay, thank you very much. Thank you for the InMode company for the trust in my practice. Thank you.
Thank you, doctor. We have just one question by the moment.
All right.
Ask contraindications.
There's no contraindication. I mean, there's no single contraindication. I mean, you have a contraindication if you have a skin sores or skin oncology conditions. You have you cannot use it if there's pacemakers. You cannot use it if you have rosacea in this area. But the contraindications they are always relative, or mainly relative, because I would say a good contraindication is a poor candidate selection. I mean, if you have a very important fat prolapse, you have a very important laxity, or you have a skin lower eyelid retraction, or you have a very important asymmetry, that's a contraindication, in my opinion.
Perfect, thank you. We have another question. What would you recommend in case of treating lower eyelid in a patient with xanthelasmas? Would it be a contraindication?
I don't think so. I don't think so. You're hitting the tissues. I don't think there's going to be a contraindication. The xanthelasmas. The xanthelasmas are placed in a very, very upper position of the layers of the whole thick of the eyelid. So you are hitting from below to the upper area. I don't think it's going to be a contraindication. To be honest, I don't have experience with that, because I used to treat xanthelasmas with CO2 laser resurfacing or some other technologies, or removing with surgical techniques. But that if you want to tighten the tissues that are under the xanthelasma, that would be okay. It won't worsen the appearance of the xanthelasma, I'm sure.
Thank you. Another question, you're asking if you can tell us parameters in this area against the tools that you're...
Okay, the parameters in this area, as I used to say, are needs to be very, very well selected in every single patient. I mean, you need to understand what are you looking for. If you need to talk with the patients how many days after the treatment does the patient has after for recovery. If you are looking, if the patient says, okay, I do have 2-3 weeks, then you can look for a more aggressive treatment. You can go for a higher temperature. You're going to look for 16 bathios, and that's okay, because the patient will have edema or inflammation after the treatment for 10 days, and then that's okay. But if the patient says, no, I just have 4 or 5 days for the same condition, then you need to rise down the parameters. To answer the question, I would say never go over 15 bathios, or never go over 45, 15 degrees in the internal pole. Okay, outside is not that important because you are going to rise 35, 40 degrees, but the internal pole, something like 45 degrees, 50 degrees, sometimes depending on the patient, you can go for a 55 degrees, but I don't think it's gonna be doesn't worth, because it's gonna take you for a more important liquid edema. I mean, it's gonna take you a very important edema and inflammation, and can take some, if the patients are a smoker, can take you like 2-3 weeks to remove all the liquid that's been creating after the heating of the tissue. So, in my opinion, most of our patients could be worked with if you have a good candidate selection. For upper eyelids, I would say Morpheus always in 1-2 millimeters depth, okay, with a 30 bathios more or less, 30 bathios, so could be okay. And for the lower eyelids, same thing, 1-2 millimeters. There's no need for go to 2-3-4 millimeters depth of the Morpheus, and for like 30-35 bathios. And when you are working with Accutite, we are working not always in bathios. We are working in temperatures, in terms of temperatures, and which temperature are we willing to achieve, right? So if you're willing to achieve a external temperature of 40 degrees, it's okay, but internal degrees should be like 50, 55, not more.
Okay, thank you, doctor. Another question: where do you put the entry points?
Where do I place the entry points? You can do it wherever you want to. I mean, it's not a very important deal. It's not a big deal for us, because you just need to do a slide, a small hole with a 21G needle. And what I would say is that let me take you to another picture at the beginning. So because there we can see where it's going to be difficult here. I'll do it with the keyboard. Okay, once you try to go, for example, let's say this patient. Okay, imagine that we need to treat this more pigmented area, this area. Oh, sorry. Here of the lower eyelid. Imagine you want to treat this. Okay, the length of the probe, of the internal probe of the Accutite handpiece is like from here to here, like 6 centimeters. All right. Then you need to do the hole a bit 1 centimeter away from the area that you want to treat. Okay. If you want to treat from here, then you do the hole maybe here, okay? Because once you introduce the probe, the internal probe, if you're doing a retrograde fashion, you are hitting this area, but you need to avoid to hit the area around the hole, because then you can have a bad healing of the hole. Okay, if you hit that directly with the Accutite. So you do the hole and then you treat the area that is 1 centimeter away from the hole. Right?
Perfect. Yes. We have another question. Would you perform microfat transfer at the same session? And if yes, how long after Accutite?
All right. The question is, if I do microfat transfer for periocular area at the same session, that's okay. That's a good question. Listen, theoretically, when you're doing a microfat or autologous fat transfer, you need to place the fat as deep as you can, periodically, as deep as you can. So, and when you are working with the Accutite device, you are heating, but in over the septum or in a intermediate layer area. Okay, so I would recommend to do that only if you are not placing the probe of the Accutite very deep. Only that cases. Okay, I mean, when you if you are doing a autologous fat transfer, for example, for middle third or for the TROUGH, that's okay, because the fat will be placed very, very, very deep in touch with the bone. And when you are using the Accutite device, you are heating and placing the probe underneath the orbicularis muscle. There's enough distance between both products. I mean, the probe and the fat. There's enough distance, but sometimes the areas are very narrow or are very thin, and it depends on the patient. You can, if you have a kind of doubt of that, I wouldn't do the Accutite at the same time. I would do the fat transfer, and in the end, I would do the couple of weeks later or a month later, I would do the Accutite. There is it is not that clear because I see pros and cons. And in terms of what would you use first, if the autologous fat transfer or the Accutite? In my opinion, I would say that you can try to do the Accutite and then achieve the improvement in the tightening of the tissues. You will find it like a month later. Just you need time for the fibroseptal network to shrinkage, to remodeling the collagen, and you need time. You don't see a result, an immediate result. You need like a month. And once you achieve that, then you can do the autologous fat transfer safely. That's my opinion, but I think there are some colleagues that are doing the other way around, and for sure they have the reasons. I cannot say that there's only a way to do things. But to sum up, if you have a doubt, if it's a good moment to do both things at the same time, then don't do it. Do one and then do the other. Or if you want to do it at the same time, you can do it with Morpheus. Then you place the 4 millimeters, then 3 millimeters, then 2 millimeters, then 1 millimeters with a higher
power.
That's it, vatios or millijoules per pin. That's in United States and Canada. But I would say that with both technologies, you are working safely.
Great, thank you. Another question: with low set eyebrows, did you try raising the brows, let's say with Botox or treats, for example, and then do you Accutite for eyelids?
Sorry, I don't get the point of the question. I hear you not very good. I can hear you. Can you repeat, please, Clara?
Yes, if you have low set eyebrows, did you try raising the brows first with Botox or treats, for example, and then do you Accutite for the eyelids?
Okay, the question is if you have a low set position of the brows, if you try to raise the position of the brows first with Botox or with threads and then do the Accutite. Okay, you can do it. There's no, you can do it. But if you want to raise the brows itself with the Accutite, then you better try the Accutite first, and after that, do the threads or the Botox if you need it. But if you are looking only for skin conditions of the eyelid, you can do that at the same time if you want to, because there are different areas. In my opinion, when you have some kind of patients, I will show you again, these patients, that's okay, you use it, that there's no reason why you cannot use it at the same time. But if you have, for example, this patient, for example, this patient, would you be confident enough to be sure that you're going to raise the brows enough to take a more open, wide look? Do you think that you can achieve a good result using Botox or threads to raise the brows in this heavy brows patient? I don't know if you feel confident enough, but in my experience, I don't feel confident enough. I think this patient is surgical patient, and if you wanna raise the brows enough, you need to go for surgery. Then, after being said this, okay, you can, if you're treating brows and the skin of the eyelid itself, you can do it at the same time if you want to, but it's not that common for me. Most of my patients are looking for treatments that are minimally invasive, that last like 2 years, 3 years. That's what Accutite can offer you. Botox will offer you not more than 4 or 5 months results.
Okay, thank you. We have another question. What would be the enter point in the upper eyelid?
Okay, the enter point for the upper eyelid could be the tail of the brow, like here, as I have said, right here. Okay, let's take a look for another view like this. In this patient, for example, I wouldn't recommend to treat the upper eyelid with Accutite. There are no skin excess, there is a very important PTOSIS, there are only a slight fat prolapse in the internal fat pad. Okay, you can try to go to improve this fat pad with an Accutite. Then the entry point of the needle could be from here. I don't know if you are looking at the black arrow. Are you looking? Can you see it, Clara? Yes. Okay. From here, then the probe around here. Okay, over the septum. Okay, but this fat is behind the septum. Okay, so the heat will improve only partial improvement. You will achieve a partial improvement. And I wouldn't recommend you to treat this patient, for example, because if you remove this fat, okay, you will not see this fat. The patient will not see this fat, but the appearance of the round eye will be worst, and the appearance of the PTOSIS will be worst, because then this, if you want to, for example, to remove this fat, then this will look very hollow, and the hollowness in this area will worsen the appearance of the round eye. But if you want to treat it just because of the patient says you insist and says I want to remove this fat pad because I don't want to see it. Okay, do it. Do the entry point far away enough where the areas where you're gonna hit. Like 1 centimeter away from, right?
Okay, thank you. Another question: do you normally use tumescent solution? And if so, how much?
If I use tumescent solution, if so, how much? I do not use tumescent solutions for eyelids because there's an area that there's no need for very important quantity of anesthesia. I used to perform it under local anesthesia, and as far as we are surgeons of the eyelids, we're used to to use the anesthesia for every single surgical procedure. And I would say that with 3-4 milliliters of lidocaine 2% combined with 2 milliliters of bupivacaine at 0.5% would be enough.
Good. When can we repeat the session? We have this question from another doctor.
When do I repeat the session? It depends of several points. I mean, if it depends of the downtime of the patient has. I mean, if they say, okay, I have 1 month recovery, you can do everything in only one session. And after the treatment with one session, you maybe will not need another session in 2-3 years, probably, okay? But most of our patients, they are working, they don't want to have a very long downtime, they want to have a slight change, they want something softer. So you raise down the parameters of the console, and then you'll achieve partial result, and then maybe you will need another session next year, or in a few years, or a few months, but depending on the condition. I mean, if you're treating this patient, for example, I said that you shouldn't treat him, but let's say that we treat this patient. This is very bad patient because of the negative vector, because of the laxity, because of the PTOSIS, and so on. You treat it, you improve a little bit the appearance of the skin, that's okay. But this is very bad condition, and there is a very bad tissue laxity to work with. Then probably the laxity of the tissues will appear again in a shorter period of time. So it depending of what you consider. For example, if you're treating this patient, this patient is absolutely different because there's only a few skin wrinkles, a moderate or mild hyperpigmentation. If you treat this patient, you will probably achieve a good result in only one session without very high temperatures, and the result will last for sure more months than in the other patient. So it depends.
Okay, thank you. Dr. Benajiba, he's asking, how do you manage the flexibility of the probe?
How do you manage the flexibility of the probe?
Yes, of the probe, of the Accutite.
The flexibility, you mean? You cannot, okay, if you don't need to be very, if you work smooth, you work with a soften, you are, there are no irregularities in the periocular area. You just go through with the probe and then go back and then do the same movement, but there's no risk for the probe to be broken because there are no irregularities, and you are not punching against bone or against any other hard structure that could bend the probe. That's not a risk. That is something that will not find in the periocular area.
Yeah, thank you. Last question. When we will see the maximum results after the Accutite treatment of the lower light, so that we can tell the patient beforehand?
If I understood properly, it said that the question is how, in what moment will you say that this is the maximum result? Yes. Okay. One more time, depending on the quality of the tissues of the patient. When you are hitting the soft tissues, you are looking for an improvement in the 3 layers, in the skin, in the deepest areas of the skin, and in the subdermal fat, and in the fibroseptal network. Okay, because there is some collagen that with the heating will appear new collagen, and there's a remodeling of the collagen. But it's something that takes time. I would say like 6 months could be a good moment to take a look to a final result. When we are using this kind of products, most of you use Radius or you use LNC or some other collagen stimulating products. They're more or less the same, but this is much more powerful. Okay, so you need a shorter time to see results, like 6 months, I would say.
Thank you so much, Dr. Genol. This was the last question.
Thank you.
We really appreciate your effort on this webinar and presentation, that it was really complete and amazing. So thank you so much. We hope to find you in our next webinar.
Okay, thank you. Thank you all. Thank you for the questions. That are very interesting questions. And if any other further questions needed, or you can look for me in the Instagram or talk with InMode company, or I'm here to give my point of view, and I hope it's going to be helpful for all of you. So thank you very much one more time, and I hope you're doing well, and please stay home. Bye.
Bye, thank you.
Thank you, Dr. Bye.